Thanks so much, Rebecca. I'm very excited to introduce our next speaker. Nadine Ezard is a professor of medicine at the University of New South Wales, the director of NCCRED, and a clinical director at the Drug and Alcohol Service at St Vincent's Hospital in Sydney.
Thanks everyone, and thanks to our wonderful speakers so far. Just acknowledging I'm on unceded Gadigal land. We will be going a teensy bit longer. We were going to have a break at 3. I think we might be taking a break a little bit later just so we've got time for a wonderful panel after this as well. I'm going to talk about the Lisdexamfetamine for methamphetamine dependence trial that we ran at the time. DSM-5 wasn't invented yet, so we called it methamphetamine dependence. The classificatory systems have shifted. The people are the same. I'm just going to thank all my co-authors, particularly Nick Linzeris, who's not here today, but he was the senior author on this, but there are also a number of co-authors in the room, and also some some of the research coordinators are in the room, so thanks particularly to Miriam and Michelle, who worked on this trial. The study was funded by NHMRC, also got some other funding from a range of other foundations and funding sources. NCCRED is gratefully funded by the Department of Health, Disability and Ageing. I'm employed by St Vincent Sydney into the New South Wales health system, and I've got no other conflicts to declare, no commercial conflicts. This work was conducted in many different parts of Australia, not only on Gadigal lands, but also Awabakal and Warramai people in Newcastle, Darug people in Western Sydney, Bunurong and Wurundjeri people from Melbourne, and the Kaurna people in Adelaide, South Australia. So we thank particularly those people. We also acknowledge the contribution of people with lived and living experience to the project. So the participants in the trial, but also the actual reason we studied this trial was a client of mine who came up with the idea, and they want to remain anonymous, but they did say, hey, there's this new drug that's just been approved for ADHD in Australia. It's got a more predictable onset of action, longer duration of action, less variable according to urinary pH. I think you should try it. So we did, so thank you. And also respects to Ni Fung, who was one of the researchers that started the trial with us and didn't managed to stay around to the end, but we are paying respects in memoriam. So we've got, I think Didier's set the scene pretty well for the urgent need for some sort of pharmacological intervention. There are psychosocial interventions. They're of modest effect. They're particularly not so effective if people are using more often than every second day, pretty much. So the kind of group of people actually that Rebecca was talking about as well. So we wanted to try, as different from the kind of rationale behind metazapine, we wanted to try an agonist medication, so something with a similar action to the drug that people are using. And the kind of rationale behind that group of drugs is that it might be a safer dose, so or potentially a safer route of administration and potentially fewer effects, and certainly more predictable effects if it's a pharmaceutical good manufactured product. And we know that from other substance use disorders like nicotine, tobacco, smoking dependence, or like opioid use disorders, there is pretty good evidence that this approach can help people shift their relationship with a particular drug. And the idea is that it does two things, that it attenuates the negative reinforcing effects, so it treats withdrawal. So the kind of drivers that for methamphetamine particularly, you feel tired, foggy, can't think straight, exhausted, so it treats, so then you're forced to keep using. The idea is that it treats those kind of withdrawal effects. At the same time, the theory behind this class of drugs anyway, agonist medications, is that it provides tolerance to the positive reinforcing effects. So when you use on top, if you've already got quite high tolerance, you don't feel so much of the positive effects, so it sort of breaks that kind of reinforcing cycle. But I think with methamphetamine particularly, the potential advantage of these kind of stimulant drugs is that it treats the withdrawal effect that's driving kind of ongoing use. The other thing is that it can provide a framework for regular healthcare and psychosocial intervention, so the kind of things that Didier talked about, the other important treatment of coexisting physical and mental health conditions. I mean, I was particularly struck by the mortality rate due to stimulant use. So when we're not sufficiently addressing the kind of physical health comorbidities as well. So if we have a treatment that works, we've seen the number of people that came forward for Rebecca's study who hadn't accessed any kind of treatment for anything. So if we have something to offer people, we can also offer some of the other things that we know we've got. So lisdexamfetamine is a prodrug of dexamphetamine. It's used for both ADHD and binge eating disorder up to 70 milligrams a day. It's turned into dexamphetamine in the red cells. So its properties are pretty much identical to dexamphetamine, but your red cells have to kind of cleave off the lysine part of the molecule for it to work, which means that even if you crush it up and inject it, it's not going to have a rapid onset of action. So we thought maybe theoretically that the policymakers and the people that make decisions about access to medications will be less cautious with this, because in theory there might be less of a market for the drug. The other thing is that it's once daily medication, so we use dexamphetamine off-label, and it really should be 3 times a day medication. So lisdexamfetamine's once a day, and as my client pointed out, slower onset, lower peak concentration, longer duration of action than immediate release dexamphetamine, which is what we've got in this country. In other countries, there is actually a slower release preparation, but we don't have it. We first did a pilot, so 70 milligrams is what it's approved for, and we wanted to make sure that we didn't think that was going to work for people using 100 milligrams, maybe a gram, maybe more a day. 70 milligrams, the kind of dose you're using for kids with ADHD is sort of not going to touch the side. So we wanted to make sure it was safe up to 250 milligrams in people using methamphetamine. So we piloted it. Didn't seem to be any trouble. So then we were lucky enough to get a grant to go on and do a multi-centre 12-week course of 250 milligrams a day. So people were randomised to either 250 milligrams of lisdexamfetamine or an identical placebo, and they were also offered 4-session manual-based cognitive behavioural therapy, so an evidence-based intervention if they wanted it, but it wasn't compulsory. And we were fortunate that 6 clinics ran the trial for us, and people had to be, because we were cautious about giving a high-dose stimulant on a daily basis, which we know has cardiovascular effects and can cause psychosis, we wanted to make sure that we weren't putting people at extra risk than they were already at. So and because people that are using frequently, the psychosocial interventions don't work so well for, we thought we'll just target that group for whom we have really very little. The primary outcome was past 28-day methamphetamine use on self-report at the end of week 12, but we also looked at the total methamphetamine use across the 84 days. And then we looked at a range of other secondary outcomes, including craving, withdrawal, physical and mental health treatment satisfaction, and use of other substances. You can see from here, if you, I don't know if you've still got in your head Rebecca's group, I think it's quite interesting to do the comparison. Our group, mainly men, 60% men, which does reflect our treatment population, probably does not reflect the people who are looking for treatment for methamphetamine. So we're missing some people there too. Bit older than, a little bit older than Rebecca's group, or about the same age, yeah. So heading to 40, so people have been using really for quite a long time before they've come forward for treatment. Using nearly every day at baseline, and then about 40% actually screened positive for ADHD at baseline, which is also of interest. Here's the findings. So only very weak evidence at the last four weeks at week 12 of a difference between the placebo and the lisdexamfetamine group, but both groups decreased, as you would expect in a trial. So what we're looking for is above and beyond what the placebo group did. But over the 84 days, there's around a nine days difference in the lisdexamfetamine group, which wasn't the primary outcome. The primary outcome we were looking at was the last 4 weeks before week 12. This trial was deeply affected by COVID, so we had to manage the shutdowns around the public health measures around COVID, and had to shift. We had to stop recruiting, we had to shift the way we were delivering the trial, so it was affected by that. So in the end, we probably, on a post-hoc analysis, probably had about a 60% power to detect what we wanted to detect. The other important outcomes were no serious safety concerns, no difference in retention. What I find particularly interesting is that people like the drug. So when you ask people, do you like it, we really had quite significant difference. Remember, this is placebo-controlled, so people didn't know what they were on, although more people guessed correctly that they were on the active group, active medication. But really, people liked the drug. And interestingly, this wasn't a group of people that wanted counselling. They had access to counselling. That's not what they were looking for. They didn't come. So both groups only had about one session of counselling each. So cautiously, we can conclude that the conclusions are in line with the guidelines that Didier presented before, that in kind of a controlled environment prescribed by someone who's got a lot of training and capacity to follow someone up, and in the setting where someone might have access to other kind of psychosocial interventions, then perhaps we can use Lisdexamfetamine, given if you have the right regulatory environment as well. It does appear that at higher doses it's well tolerated and liked. My takeaway in this is that if people don't see a change in their relationship with methamphetamine, or see a change in the frequency or dose of use within the first 4 to 8 weeks, it's probably not going to be a drug for them. So that in terms of your practice, off-label practice, that could be helpful. Future research on stratification by ADHD status, we weren't sufficiently powered to tell there was no difference between people who screened positive for childhood symptoms of ADHD, but I do think future research does need to stratify by those two groups, because we don't know if there's a differential effect there, and our treatment populations have very much higher levels of coexisting ADHD than in the general community. And finally, we really need further discussion on what a clinically meaningful outcome is. Is 9 days different? Is that important for people or not? So that's our discussion that we need to have here. Thank you.